Good afternoon, and thanks for joining us for today's ZOHU call. The webinar will begin soon. Please stand by. Good afternoon. The webinar will begin soon. Please stand by. Hi, everyone. I'm Keisha Bohannon, and I work in the National Center for Emerging and Zoonotic Infectious Diseases at the Centers for Disease Control and Prevention. On behalf of CDC's One Health Office, welcome to the May 7th, 2025 Zoonoses and One Health Updates call. Next slide, please. Although the content of this webinar is directed to veterinarians, physicians, epidemiologists, and related public health professionals in federal, state, and local positions, the CDC has no control over who participates. Therefore, please exercise discretion on sensitive content and material, as confidentiality cannot be guaranteed. Today's webinar is being recorded. If you have any objections, you may disconnect now. Links to resources from each presentation are available on our website at cdc.gov/1-health/php/trainings-events/may-2025-zohu-call.html. Next slide, please. Today's presentations will address one or more of the following 5 objectives. 1. Identify an implication for human, animal, and environmental health. 2. Identify a One Health approach strategy for prevention of public health threats. 3. Identify a One Health approach strategy for detection of public health threats. 4. Identify a One Health approach strategy for responding to public health threats. 5. List 2 ways to improve collaborative practice across the public healthcare team. Next slide, please. In compliance with continuing education requirements, all planners and presenters must disclose all financial relationships in any amount with ineligible companies over the previous 24 months, as well as any use of unlabeled products or products under investigational use. CDC, our planners and presenters wish to disclose they have no financial relationships with ineligible companies whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients. Content will not include any discussion of the unlabeled use of a product or a product under investigational use. CDC did not accept commercial or in-kind support for this activity. Next slide, please. Instructions for receiving free continuing education are available at cdc.gov/1-health/php/zohu/index.html. CE will not be available for today's live webcast, but it will be available for the web on-demand course once the recording is posted. A captioned video of today's webinar will be posted on our May call page within 30 days. Next slide, please. Before we begin today's presentations, CDC's One Health Office Director, Casey Barton-Baravish, will share some news and updates.
Greetings. We are very excited to bring you the May ZOHU Call, and we appreciate you all being here today. We ask that you share the ZOHU Call website link with your colleagues from public health, agriculture, wildlife, plant, environment, and other fields and sectors so we can let them know about the live and recorded webinars and free continuing education that the ZOHU Call offers. So before we start the presentations, we'd like to share some monthly updates and resources, and you can find links to these resources in today's ZOHU Call email newsletter. If you are not yet subscribed to the newsletter, you can sign up using the link on our main ZOHU Call webpage, so you'll get these updates moving forward. CDC is working closely with federal and state and local partners to monitor the H5N1 bird flu outbreak in people, wild birds, and poultry, dairy cows, and a range of mammals. You can find the latest updates on CDC, USDA, and FDA's websites, including situation updates, recommendations for protective actions for people, confirmed cases in domestic livestock and other animals, and more. In today's newsletter, we will highlight several, and next slide, please. We will highlight several recent publications, including a publication on the current measles outbreak in the United States. Additional publication highlights include emerging infectious diseases publications, another discussing the concurrent norovirus outbreaks across multiple local health jurisdictions in California, linked to the consumption of raw oysters, and finally, a publication on the topic of controlling the cross-border spread of livestock diseases. Next slide. The ZOHU newsletter also highlights recent announcements and resources, including a webpage dealing how listeria spreads through dairy products, a clinician update on the human cases of H5N1 and outbreak monitoring efforts, and a recent COCA call, including a discussion on the reemergence of murine typhus in the United States. Next slide. Here are the May observances that might be of interest to you. Just to highlight a few, this month of May is Lyme Disease Awareness Month, and also Happy National Pet Week, which is May 4th through the 10th. And in addition to other observances listed, the World Organization for Animal Health, or WOA, has their 92nd General Session of the World Assembly of Delegates that will be taking place the week of May 25th through 29th at their headquarters in Paris. Next slide. Finally, we have shared several new and ongoing outbreak investigations, including a salmonella outbreak linked to pet geckos, as well as a listeria outbreak linked to supplemental shakes. And as always, you can visit CDC's Healthy Pets, Healthy People website for a selected list of ongoing and past U.S. outbreaks of zoonotic diseases. And linked from today's newsletter, you can find details about additional ongoing U.S. outbreaks. We encourage you to continue to send presenter and topic suggestions for future presentations, news from your organization, and feedback to us at zohucall@cdc.gov. That's ZOHUCALL at cdc.gov. Next slide, and back over to you, Keisha. Thank you.
I am back online and I don't know where we left off, but it's silent, so I am assuming that it's my turn to speak. Sorry about that. I did have some connection issues just now. Give me one moment to get to my place.
Yes, Keisha, I
So
had just turned it over to you, so glad you're back because I was trying to contact you.
okay, great. Well, thanks, Casey. You may submit questions at any time using the Q&A feature. Please include the topic and presenter's name. The Q&A session will follow the final presentations if time permits. You may also email questions to today's presenters. We've included their email addresses on the slide and in today's newsletter. Now I can introduce our first presenters. Next slide, please. Doctors Lisette Duran and Ramya Naraharzetti will present on highly pathogenic avian influenza virus infection of indoor domestic cats within dairy industry worker households. Please begin when you're ready.
Thank you very much, Keisha. Next slide, please. Hello, thank you very much for having me. I'm going to give a brief background on highly pathogenic avian influenza A, H5N1, to set the scene for Dr. Naraharasati. Highly pathogenic avian influenza refers to a flu virus that can cause severe disease and high mortality in infected poultry. It causes little to no disease signs in certain wild aquatic bird species. There are multiple highly pathogenic avian influenza, or HPAI viruses. The HPAI virus that we were discussing today is HPAI A-H5N1, which was first detected in wild birds in China in 1996, resulting in poultry outbreaks and several human cases. Since 1996, H5N1 viruses have circulated in wild birds and have undergone multiple genetic diversification events. In 2020, a new type or clade of H5N1 virus emerged, which we call clade 2.3.4.4b, and began to circulate in unprecedented numbers in wild birds around the world. Globally, this virus has become widespread, causing record numbers of outbreaks in wild birds and poultry. By the end of 2021, H5N1 was detected in wild birds in North America. And in February 2022, outbreaks of H5N1 were detected in commercial and backyard poultry in the United States. In March 2024, H5N1 was detected in dairy cattle for the first time in the US. And then in April 2024, the first human case of H5N1 associated with dairy cattle exposure was detected. All of this background is provided to say that H5N1 is not a new threat. There's a lot we know and understand about this virus. However, given the current situation, dairy cattle is new, there's still a lot that we're learning. Next slide, please. The brief update on the CDC human case investigation. Since March 2024, 70 human cases of H5 have been reported in the United States. There have been 41 human cases of H5 among dairy workers with occupational exposure to infected cattle. These cases were reported in 5 states, 1 each in Texas, Colorado, Nevada, 2 in Michigan, and 36 in California. Additionally, 24 cases have been associated with poultry exposures, 9 of which occurred in Colorado in July 2024, 11 confirmed in Washington State in October 2024, and 1 detection in Oregon, Iowa, Wisconsin, and Ohio. All cases were among workers depopulating poultry infected with H5N1. Both the dairy and poultry exposed cases were detected through active surveillance, and all cases were clinically mild, offered antivirals, and were not hospitalized. There have also been 3 cases of H5 with no known animal exposures. In September, a hospitalized Missouri patient tested positive for H5. They had underlying medical conditions, given antivirus, discharged, and then recovered. A pediatric case in California in 2024 was the first pediatric case of H5 and one reported in the US. This person had mild respiratory symptoms, given antivirus, and recovered at home. In the second pediatric case in California in January of this year, this person also had mild respiratory symptoms, given antivirus, and recovered at home. Additionally, there have been 2 people who had exposures to backyard poultry. In December 2024, one older adult in Louisiana, this person experienced serious illness, was hospitalized, and passed away in early January of this year. This has been the only death attributed to H5N1 in the United States. Then in February 2025, an adult patient in Wyoming experienced serious illness, was hospitalized, and has since recovered. Currently, there has been no known human-to-human transmission identified in the United States. Next slide, please. Thank you. Now I want to talk a little bit about H5N1 in domestic cats. So the first case of H5N1 detected in domestic cats occurred in Thailand in 2020. I'm sorry, wrong date, 2004, not 2024. I apologize for that typo. The case was reported in a manuscript in 2006. The presumed source of exposure was consumption of a pigeon carcass. The cat's owner described that within days of eating the pigeon, the cat experienced elevated body temperature, panting, was depressed, it had convulsions, and was ataxic. On necropsy, multiple pathologies were observed, including cerebral congestion, conjunctivitis, pulmonary edema, severe pneumonia, renal congestion, hemorrhage, and intestinal cirrhosis. And various histopathology showed non-suppurative encephalitis, gliosis, mononuclear infiltration, vesiculitis, congestions of both the cerebrum and cerebellum, interstitial pneumonia, congestion, and multifocal necrosis of the liver. Next slide, please. So since 2006, multiple countries have reported cases of H5N1 in domestic cats, and these countries include the Netherlands, Thailand, Iraq, Turkey, Germany, Austria, China, Poland, France, Italy, South Korea, and the US. They're also having cats that were experimentally infected with H5N1 to see the course of infection. In these cats, we've seen similar respiratory symptoms as described in the first case, with neurologic symptoms and certain non-specific symptoms, including fever, anorexia, lethargy, and death. Again, the pathology findings were similar to what we saw in the first case described from Thailand. There was pulmonary edema and congestion, interstitial cirrhosis, hemorrhage, pericardial transudative effusion, liver and pancreas lesions, and renal congestion. Next slide, please. Okay, so apologies for this slide, did not seeing that correctly. So since 2024, March 2024, USA has reported over 100 cases of H5N1 in domestic cats. Again, the reported clinical signs are very similar to previous reports, including respiratory, neurologic, and non-specific findings. Pathology findings, again, are very similar to what we have seen in previous reported cases. And the routes of exposure have been documented to include infection from living on an affected dairy farm, consuming raw milk that either on a farm or commercial, consuming raw chicken products, raw pet food, fomites, possible farmite exposure, and exposure to wild birds, waterfowls, and mammals. So this concludes my portion of the presentation, but before I end, I wanted to give thanks to Liz Ziegler, who was a veterinary epi-elective student that assisted with the slides for this presentation. Thank you very much for your time, and happy to answer questions via chat when available. Oh, so sorry, we missed the slides, but just that last slide, if you remember, that star represented the cases that we will be talking about now. Thank you. Yeah, so thanks.
Thank you, Dr. Durand. Good afternoon. Next slide, please. In May of 2024, the Michigan Department of Health and Human Services and the Mid-Michigan District Health Department were notified that an exclusively indoor cat tested positive for HPAI H5N1 virus. Next slide, please. In the same week, a second exclusively indoor cat in the same county, but a different household, tested positive for HPAI H5N1 virus. Next slide, please. Both cats were tested due to known occupational exposure of their owners and severe signs of illness in the cats. Next slide, please. Both cat owners with occupational exposure exhibited some symptoms prior to illness onset in cats. They both refused or did not follow up with testing. Other household members tested negative for HPAI H5N1. Next slide, please. The resulting public health investigation demonstrated that given the potential for fomite contamination, farm workers are encouraged to consider removing clothing and footwear and to rinse off any animal byproduct residue, including milk and feces, before entering their households. Next slide, please. Veterinarians in states with confirmed HPAI H5N1 in animals including dairy, cattle, poultry, and wild birds should consider the following when evaluating companion cats with respiratory or neurologic illness: obtaining household occupational information, testing for influenza A viruses, and wearing personal protective equipment. Next slide, please. It is important that veterinarians contact state and federal public health and animal health officials with suspected cases to collaborate on joint One Health investigations and testing to protect human and animal health. Next slide, please. To begin, we will share about the identification of the first case and how public health was notified. Next slide, please. Household 1 included 2 adults, one of whom was a dairy farm worker, 2 adolescents, and 2 other exclusively indoor cats. All 4 human members of the household had daily contact with the 3 cats in the home. One of the additional cats showed signs of illness but was not tested, and the other cat, which did not exhibit signs of illness, tested negative for HPI H5N1. The dairy farm worker removed clothing and shoes prior to entering the household and did not directly work with animals on the farm. They did not report wearing PPE while on farm premises. The farm was not a known positive for H5N1 at the time, and the farm worker reported gastrointestinal symptoms that preceded the onset of illness in cat 1A. They refused testing and post-exposure prophylaxis, or PEP. The household members were tested by RT-PCR and given 10-day PEP. Both adolescents reported symptoms. One tested positive for another respiratory virus, and the other symptoms were attributed to allergies. So throughout the next few slides, I'll be referring to this household as household 1 and the cat as cat 1A. Next slide, please. Cat 1A, the index cat, was one of 3 cats in household number 1. It was a 5-year-old female spayed domestic short hair. It was exclusively indoors, as reported by its owners, never having left the home since its adoption. Next slide, please. The cat began, previous slide, please. The cat began with signs such as decreased appetite, lack of grooming, disorientation, and lethargy, followed by progressive neurologic deterioration. The cat was evaluated on the 4th day of illness signs at the Michigan State University Veterinary Medical Center, where it was euthanized due to rapid disease progression. The veterinarians on duty inquired about occupational exposures, given guidance from the state veterinarian at the time to submit suspected samples to MSU's Veterinary Diagnostic Laboratory due to known positive dairy farms throughout the state. The cat's household was also located in a county with known positive dairy farms. Brain and nasal swabs were tested with RT-PCR and genetically sequenced to identify clade 2.3.4.4b, genetic genotype B3.13, which is indistinguishable from viruses circulating in Michigan cattle at the time. The initial result initiated a public health investigation by the Michigan Department of Health and Human Services, along with the Mid-Michigan Department of Health. Next slide, please. Household 2 included 1 adult who was a milk hauler who transported raw milk and 2 cats. The owner had regular contact with both cats daily. The dairy farm worker did not remove clothing prior to entering their household and reported that cat 2A, as I will be referring to it, would roll around in their work clothes. They did not report wearing PPE. The worker transported milk from several farms in the county, which had several known H5N1 positive dairy farms, but it was not confirmed whether these farms that the dairy farm worker worked at or hauled milk from were positive for HPI H5N1. The farm worker reported eye irritation that began 2 days before illness onset in cat 2A. The owner initially agreed to testing and PEP, but was lost to follow-up, stating fear of losing employment. Next slide, please. The second positive cat, cat 2A, was one of 2 cats in the household number 2. It was a 6-month-old male intact Maine Coon. It was exclusively indoors as reported by the owner. Cat 2A was evaluated at MSU VMC, or the Veterinary Medical Center, within a week of Cat 1A. It showed signs of progressive neurologic deterioration, anorexia, lethargy, and facial swelling. On physical examination, it was found to be obtunded with abnormalities of cranial nerve function, abnormal motor function, puffiness of the eyes and nose, and minimal movement. It succumbed to illness within 24 hours of illness onset. Again, the veterinarians on duty inquired about occupational exposure due to known positive dairy farms throughout the state, and the cat's household was also located in a county with known positive dairy farms, the same county as Cat 1A. Cat 2A was also tested with RT-PCR, and the samples were genetically sequenced. It was determined that the clade and genotype were again indistinguishable from those circulating in Michigan dairy cattle. The additional cat in the household did not show signs of illness and tested negative for HPIA H5N1. Next slide, please. Veterinary staff who interacted with the two cats were monitored for 10 days by public health authorities. 24 staff members were potentially exposed, and 75% were contacted and monitored. They were not offered PEP given their limited exposure. 7 individuals reported symptoms, of which 5 were tested. All tested negative on RT-PCR for H5N1. Next slide, please. In the ongoing U.S. outbreak of HPIA H5N1 in dairy, cattle, poultry, and wild birds, serious illness, including neurologic signs and death from HPIA H5N1 virus infection in cats, have been attributed to various mechanisms, including direct and indirect transmission. To date, 112 cats have been reported in the U.S. with HPI, with most of these cases being in owned pet cats, as Dr. Duran mentioned, compared to those living in dairy farms or barn cats. And this case is, of course, unique because it is owned pet cats, but with the specific known occupational exposure of only indoor cat. Next slide, please. To date, there has been no confirmed cat-to-human transmission of HPI H5N1. However, there was a cat-to-human transmission of low pathogenic avian influenza A H7N2 in an animal shelter in New York City in 2016, suggesting that exposure to cats infected with HPAI virus might also pose a transmission risk to humans. Next slide, please. While the source of infection in these two cats is unknown, the cat owners worked on dairy farms and potentially had occupational exposures to HPI H5N1, positive dairy cattle, or contaminated products or environments. Next slide, please. The 2 dairy workers described in this report did not use recommended PPE before their illness and could have been exposed to HPIA H5N1 virus. However, because neither dairy worker received testing for H5, whether Cat 1A owner's gastrointestinal symptoms or Cat 2A's owner's ocular symptoms were because of HPIA, H5N1 virus infection, or a different etiology is really unknown. Next slide, please. The resulting public health investigation demonstrated that given the potential for fomite contamination, farm workers are encouraged to consider removing all clothing and footwear and to rinse off any animal byproduct residue, including milk and feces, before entering their households. Next slide, please. Veterinarians in states with confirmed HPI H5N1 in animals should consider following when evaluating companion cats with respiratory or neurologic illness, obtaining household occupational information, testing for influenza A viruses, and wearing personal protective equipment. And I will say one other thing is that that especially when looking for these respiratory neurologic illness signs, oftentimes the cat can test negative for rabies, and then this can be a preceding evaluation by the veterinarians, and that's another sign to watch for. Next slide, please. It is important that veterinarians contact state and federal public health and animal health officials with suspected cases to collaborate on joint One Health investigations and testing to protect human and animal health. Next slide, please. We wish to acknowledge the Michigan Department of Health and Human Services, the Michigan Bureau of Laboratories, the Mid-Michigan District Department of Health, and the Michigan State University's Veterinary Medical Center and MSU's Veterinary Diagnostic Laboratory. Really amazing collaborators that made this investigation possible so quickly after the initial cases of human cases in the month prior that were identified, and really made for the testing and work to be done in an efficient way. Thank you.
Thank you so much for sharing, Drs. Duran and Nara Farasetti. Okay, so our next set of presentations will be given by Drs. Willie Lanier, Kristen Jankowski, and Miss Vicki Ramirez. They will be presenting on One Health Clinics, the Utah, Delaware, and Washington experiences. Please begin when you're ready.
Thank you. Hi, everyone. I'm Willie Lanier, State Public Health Veterinarian in Utah. It's a real honor to present today with Kristen and Vicki on the ZOHU Call. Next slide. There is a great need to overcome barriers to both human and veterinary care, and we think One Health clinics are an excellent way to do that. Listen for these 4 themes while we present. 1, these clinics can decrease barriers to pet care, so place emphasis first on the pets. 2, harness the power, really the magic of the human-animal bond to engage pet owners. 3, build trust to encourage greater utilization of the care that's being offered for both pets and their people, and achieve remarkable outcomes by engendering and leveraging human veterinary collaboration. We'll tell 3 stories of how we put these principles into action by hosting One Health clinics. Notice how the driving partner behind each of these 3 were different. In Utah, it was the public health system, in Delaware, an animal shelter, and in Washington, a university. There's no one-size-fits-all approach to this. The concept can be adapted to local circumstances. We're here to tell you that wherever you are and whatever your situation, a One Health clinic is possible and it's powerful. Here are our stories. Next slide, please. Utah's story begins with my own personal experience with COVID. In 2021, we started adding vaccination to testing centers in Utah, and many people were vaccinated that way. In other words, I learned that if you make vaccination convenient, many of the barriers go away and people will choose to be vaccinated. At the same time, I was becoming more and more convinced of the power of the One Health approach and of the human-animal bond. In 2022, I happened to notice this article on the screen in JAVMA that's co-authored by Kristen Jankowski about a successful One Health clinic in Delaware. I got inspired and started to wonder, could something like this be done in Utah? That led to some great interactions with One Health partners, and voila, next slide, please. I'm going to tell you about our One Health vaccination clinic in Utah. And there's a picture of me holding one of our patients. Next slide. We held our clinic on Saturday, October 26, 2024, from 9 a.m. to noon at the Grantsville, Utah Senior Center. It was led by the Tooele, Utah County Health Department. Next slide. This was our drive-through clinic layout. In the top left, vehicles would enter and people would register. Notice the grass next to the vehicle line. It's very important to offer a place for pets to relieve themselves if needed. Also, notice the Grantsville Senior Center in the lower left, which the managers kindly left unlocked for us in case we needed to relieve ourselves. We also had some vans and supplies as indicated in the lower part of the diagram. After people drove into the clinic, we had 2 lines, one for humans only and another for pets only, or humans plus pets. People pulled forward to the respective vaccination stations, represented by tents here in the diagram. The upper tent is the human team, and on the bottom is the pet team. Pets and or their people would be vaccinated in their vehicles or next to their vehicles, or sometimes we would vaccinate a fractious cat in one of our nearby vans, depending on the situation. People would then exit clinic in their vehicles to their right. Next slide. For pets, we offered rabies vaccinations for free, thanks to rabies vaccines donated by the Indian Health Service. People were also able to pay a reasonable fee out of pocket for other pet services, distemper, parvovirus, bordetella, and Lyme disease vaccinations, as well as deworming and microchipping. For humans, we offered influenza and COVID-19 vaccination. We charged insurance, or people could pay out of pocket. Next slide. Our clinic took 3 hours. We had 18 staff, which was more than we needed, but for some reason, everybody wanted to help with this. 70 vehicles came through. We vaccinated 54 pets and about 25 people. We kept track of human doses given, but it turns out we didn't actually keep track of the number of people vaccinated. We'll keep some more records next time. Next slide. We asked a few questions during registration, and here are the results from 2 of them. How did you hear about our clinic today? Many people heard through social media. Not surprising, but helpful to know. A little bit more interesting, did the pet clinic encourage you to get vaccinated? We asked this of many of the people who indicated at registration that they wanted to be vaccinated at our clinic. An overwhelming majority of these people said yes. Now, this isn't a scientifically validated instrument or method to really answer that question, but it does suggest that having a pet vaccination clinic encouraged people to be vaccinated themselves. Next slide. All right, story time. I asked as many people who came to the clinic as I could what they thought about our innovative clinic, and they loved it. They mentioned that it was such a great idea, that it made so much sense, that it was convenient. One particular family at the clinic sticks out in my memory. An adult woman was driving in the front of the vehicle, and in the back were her mom and their dog. I asked what they thought of the clinic, and they said something like, "Oh, that's why mom came today. We were bringing our dog to get her shots, so we thought, you know, we'd have to make a special appointment to get mom vaccinated, so she should just come along and get her shots too." I also posted about this clinic on LinkedIn. Next slide. And that post got a lot of attention. Since then, quite a few people have contacted me for ideas about hosting a One Health vaccination clinic where they live. This concept really seems to resonate with people. Next slide. By my estimation, our clinic was very successful. So what's going on here? For one thing, pets change the conversation. If you ask someone, will you get vaccinated for the flu? They might have a range of responses from positive to negative. But if you ask, do you have a dog? You say, oh, me too. Our dog's great. Where do you take your dog to get vaccinated? Oh, yeah, it can be tough to get into a vet clinic. Well, you should bring your dog to our free rabies clinic. And as a convenient service to the community, we're also going to be offering shots for humans too. Yep, pets and their people. Come get the whole family vaccinated. Talking about pets, I think just activates a whole other part of our brains. The human-animal bond is so powerful. As I mentioned earlier, it's almost like magic. Pets will motivate people even when other things don't. And convenience is key. It removes a lot of barriers. We think that getting their pets vaccinated might motivate people to think again about getting themselves vaccinated. In fact, I think it sets up some cognitive dissonance. Like, okay, I'm here, my dog's getting vaccinated, and I'm here with other people getting their dogs vaccinated. And I also see other people getting vaccinated. I usually maybe not all that into getting vaccinated myself, but maybe I could rethink this. Next slide. We could not have pulled this off without our awesome partners shown here. I'll just mention one, the Grantsville Police Department. It's a good idea to coordinate with your local police department regarding any potential traffic disruptions. Cuddles Pet Wellness Clinic provided our animal care. Tooele County Health Department provided human health care and really organized the whole thing, and lots of great partners. Next slide. All right, so here are some considerations if you're thinking about hosting a One Health clinic in your area. Collaborative leadership. It takes a team of leaders working together, but you really need one passionate person with a vision to kind of bring it all together. Partnerships. You need a great team of partners to take care of the many aspects of this. It takes planning, maybe 3 months or so of meeting regularly together to plan. You need both an animal health team and a human health team, and you just let each of them do what they do. You have to decide on your clinic model. Do you want a drive-through or a walk-up, pop-up clinic, or a continuous brick and mortar clinic? What's the venue? A park, vet hospital, human clinic, a parking lot? Timing. What season of the year, day of the week, time of day, and duration? Will people register ahead of time or on site, and will you need internet access for that? Think through the logistics of the clinic. Where and how will vehicles, people, and pets be moving? What are the logistics to get everything physically set up at the clinic? Get all your supplies lined up, vaccines, cold chain supplies, paperwork, pens, computer, tablets, phones, signage, safety vests, cones, chairs, tables, pop-up tents, dog poop bags, first aid. Personnel. In addition to the animal and human health teams, you will need registrars, traffic controllers, etc. I think these clinics can actually be done at low or maybe even no cost, but based on your model, you might need some funding. So how much and where from? Finally, marketing. How are you going to get the word out about your clinic? Social media, radio, TV, newspaper, posters at key locations, word of mouth, listservs, etc. Next slide. Okay, so what contributed to our success in this kind of our first major foray into this? We relied on solid partnerships. This was not our first rodeo doing complex collaborative projects, and we just built on those established relationships. We had a local One Health champion. Jamie Zwerin from the Tooele County Health Department was that passionate visionary leader who really pulled us all together and made this work. We used some strategic marketing. We build this as pets and their people in that order. And I recommend that. I think there's power in leading with pets. We put this on as an emergency preparedness exercise, which allowed us to tap into some available funding to help pay for some of the personnel costs. We were able to offer pet rabies shots for free due to the donated vaccine. I recommend that you offer something for free so anyone can at least get something. It's helpful to have a reason or a season for human vaccination. We did our clinic in the fall, so it was human flu vaccination season. It could be back to school time, so kids need to get up to date on their shots, or maybe there's something in the news that gets people thinking about vaccination, like the current measles outbreak that's happening. And we were blessed with nice sunny weather, for which we are grateful, and that, of course, helped with an outdoor clinic like we had. Next slide. Looking toward the future, we would apply some lessons learned by strengthening our marketing. We were a bit uncoordinated, and we hope to do a better job on that. We want to use local team members as much as possible. Like, we hope to partner with a local veterinary clinic. This could be a win-win where the community gets free or low-cost pet vaccines and the veterinarian gets some great advertising. We will work hard to offer free vaccines. We'll try to schedule clinics when there's a special reason or a season for human vaccination. We're going to keep more records, and we'd also really like to set things up so that we gather some data to help answer the question, are people more likely to get vaccinated with their pets? Finally, we want to expand this concept, find more willing partners to try this combo vaccination and do this in more areas. Right now, we're working with some partners to hopefully do a clinic in Salt Lake County, and partners in other areas have also expressed interest. And speaking of other areas, I'd like to now pass the baton to a person who helped inspire me to try a One Health clinic, as I mentioned in the beginning, Kristen Jankowski, who will talk about Delaware's experience. Next slide.
Thanks, Willie. I'm so excited to be here today to talk about the Delaware perspective. And I love that we're coming after the H5N1 talk, where what I heard from those professionals is that if you could develop trust and share information with groups to decrease transmission of H5N1, our team of One Health Clinic concept may help you to reach populations that have been difficult to reach in the past. So next slide. So we set some goals in Delaware, and just like Willie mentioned, to embrace the power of the human-animal bond, and we want to build partnerships. So a lot of what we had is very similar to what Willie mentioned. A big thing for us is improving trust in healthcare. So going back to that H5N1 and all our other exciting science that's happening out there, you can have all the exciting science in the world, but if you can't connect it to the people, whether it be preventive healthcare for their pets or for themselves, you need the trust to make the connections. We also want to just basically improve opportunities for people to have choices in their own healthcare. And a different aspect for our project was to provide interprofessional education opportunities for students of multiple disciplines. We basically want this to be a no-brainer of the future. And as Willie mentioned, we want to collect data to see if this works. Next slide. So our partners were a little different. We had multiple universities involved, the University of Pennsylvania School of Veterinary Medicine, University of Delaware with their undergraduate program, the Wilmington University Nurse Practitioner Program, the University of Delaware Cooperative Extension, the Delaware Humane Association, that's the shelter who was the driving force, and the Henrietta Johnson Medical Center, which was our local FQHC. Next slide. Our services were different. We focused more on comprehensive preventative healthcare for pets. So really just the whole preventive healthcare plan, everything from the rabies distemper vaccines, like Willie mentioned, FVRCP and FELV for cats in addition to rabies. We also did the deworming, offered microchipping, infectious disease testing like heartworm, Lyme, or Ehrlichia anaplasma, as well as FELV, FIV testing for the cats. We had also prescription products available. All clients could go home with flea and tick heartworm prevention every 3 months. And the 3-month was purposeful because we wanted to have them come back to get refills to provide another human health touchpoint opportunity. They did not bring their pets back for that. That was just people only for their refills. We also addressed chronic issues as much as we were possible in a once a month clinic. And had the clients also had access to low-cost spay and neuter. And as I should have mentioned that this service was so popular that all clients did need to qualify by residing in one of 2 zip codes, which are the lowest income zip codes in the state of Delaware. And they conveniently are where the FQHC is located, and that's where we worked out of that FQHC community room. For the people, we did health fair style services. I told Willie I was envious that he got right to vaccines right away. You'll see that the human health part was basically screening, talking, building trust, and helping. Really providing connections and reducing that friction to signing up to benefits that are already available to folks. SNAP benefits, health insurance, appointments. Really just building trust is what we worked on. Next slide. So by the numbers, our clinic ran for nearly 3 years before the pandemic caused discontinuation. And that's because the FQHC needed to use the community room for COVID testing and services. But we averaged about 25 to 35 veterinary visits a clinic and had about 6 to 10 human medical interactions per clinic. Our team was different because we had all the students involved. So we had veterinarians, technicians, veterinary students, undergraduate students, nursing faculty with their crew of students, an FQHC member to help people get signed up for appointments there, a SNAP benefits representative, a cooperative extension representative to talk about healthy eating. Next slide. Story time. So very quickly, I'll tell the story of Caesar, the dog, and his dad. They came to the second clinic we had, and you see that the dad was in a wheelchair, so we did all of Caesar's work in the parking lot to make that easier for him. Caesar had never had access to care before. He was about 1.5 years old. He got all his preventive health care like we described before, was set up for a neuter later, and we were happy to have connected his dad with human health services. We didn't think too much of it until a year later when his dad walked in with Caesar. And yes, I said walked in, not in a wheelchair anymore, after he had expressed that he had connected with the FQHC, learned about many different offerings they had. He had lost 100 pounds, had a new lease on life. He brought his other kitties in who had also never had access to veterinary care. They were all spayed, neutered, vaccinated, tested, flea, tick, heartworm prevention, and so on. There are many stories done about our clinic because that is one of, I would have to tell you, hundreds of happy stories that are pretty much just like that. Next slide. So our considerations were very similar to what Willie mentioned for Utah, except we had connecting multiple universities. If any of you are affiliated with universities, you can know that can be a tad bit tricky. And then mentoring the students, which for me was made it truly magical. So very fun. Next slide. So the future. So really what is the future is this. It's sharing information. It's inspiring you. It's showing that this is pretty easy and we can help the big scientists do the real work by building trust and reducing barriers. So at the Open Door Veterinary Collective, where I am now, we are working on training modules for veterinarians to show them that access to veterinary care is truly a One Health issue. And those are due to be released shortly. I've worked with the Knights Landing One Health Clinic at UC Davis through the One Health Institute, where we're developing training aspects for students. We're developing data. I have 2 papers in review right now about the Knights Landing One Health Clinic out of UC Davis. So we're collecting more data, seeing does this work? Can we teach students? Can we help patients? Can we help clients? And I'll actually be presenting about this in the UK, connecting that One Health clinics can help teach spectrum of care or contextualized care to students. So with that, I'm going to pass it off to Vicki. Next slide, and thank you for participating.
Yeah, thank you so much, Kristen, and thank you, Willie, and thanks for all for being here today. I'm going to talk really, really fast about the One Health Clinic that is started in Seattle, Washington, where we integrate human and veterinary healthcare particularly for people experiencing homelessness pets, but it can be used in any kind of model. Next slide, please. This is a collaboration that was started talking in 2016, 2017, based out of the Center for One Health Research at the University of Washington. That's where I'm based, and at Washington State University's College of Veterinary Medicine with the lead of Dr. Katie Kuhl there. Next slide. We collaborate with our federally qualified health centers here in Seattle that provide free care for folks experiencing homelessness with pets. And next slide, we also very much depend on our University of Washington University District Street Medicine Group, which is a graduate-led and graduate and undergraduate supported club for students interested in the human healthcare fields. This is a really important collaboration because they're responsible for noting the clinically relevant information during our veterinary and human healthcare clinics to pass on to the other healthcare teams so that we can actually fully integrate the care. Next slide, please. And of course, we always work with our members of the community that are servicing our houseless community members. That's case managers, emergency shelters, and particularly we try to collaborate with our community members who are living or have lived experience in homelessness. Next slide, please. So this is an integrated human and veterinary healthcare clinic where the information that comes out of veterinary, the veterinary clinical experience is used to inform the human healthcare experience and vice versa. The human health information is integrated with the veterinary care clinic so we can create a single healthcare plan for the family unit. Next slide, please. And so we've been holding this clinic twice a month since 2018 at a youth shelter and a youth and young adult shelter and clinic, and every other month for the last year with an adult population here in Seattle. Over that time, we've seen 393 human patients and 536 animals. Our veterinary team is made up of vet students from WSU, so we've seen 414 veterinary students and approximately 250 human healthcare students. So like Delaware's situation, it is an interprofessional learning clinic as well. Next slide, please. At our clinic, it's just like Kristen noted above, all the pet services are free and it's a full spectrum of care up there, but we also include behavioral support as needed. And then at our for the human health, it is general health care, all the healthcare needs for these youth and young adults that are experiencing homelessness, as well as those that are very specific to this demographic of youth. So mental health, substance use disorder, just general healthcare. Next slide, please. We have a just say hello policy where we ask that the folks come for the vet care, but they say we don't really interested in human health care, but we ask them to just say hello to the human health care practitioners. And usually that, that conversation turns into a clinical visit that day. Next slide, please. We are co-located and integrated. So the navigators check in the folks that, 5 minutes left in the whole meeting. Check in, they go to the vet care team together, they go to the human health care team together, and then they leave, they get supplies, and they go. Next slide, please. So why integration? This is a One Health clinic, so we really want to use that information so that we can best improve the health of both the pets and the animals. It allows us to address in real time the shared infectious, environmental, or behavioral health concerns that exist and create a single healthcare plan for both the family unit going forward. Next slide, please. So we looked at data across 4 years, 2018 to 2022, and there were 164 clinics held in that time period. And if you look at the slide, just looking really quick at that top, it's kind of weird, sorry. If you look, 35.4% of the folks only came in for animal health care, but 69% of those left with human health care as well. Next slide, please. So when we look at the data, 50% of the human clients who established care at the federally qualified health center, because we were there, had not accessed healthcare for 2 years prior. And of that 50%, 85% of those returned for follow-up cares with us, even on days where vet care was not provided. So in those 4 years, 80% of the clinic visits resulted in human health care. And there's a typo here, a very big typo. 69% of those indicated that they did not want or need human health care at intake. So that's lovely. Next slide, please. Because it's One Health clinic, we include questions about shared environmental exposures on intake forms and in discussions in both human and veterinary clinical visits to address those shared risks to health, like heat, cold, rain, food insecurity, et cetera. And we're able to tie care together. So one situation, a young woman talked about her cat was catching rats in the home, but then it found out because her clinical visit was that day, she was in the first trimester of pregnancy. We're able to talk about toxoplasmosis. Or if there's an animal who is in need of painkillers, but we know that the owner is on methadone and is in sobriety. How can we maintain that sobriety? How could we not put that at risk? And then we create emotional support animal letters as well, but our ESA letters include the health of the animal on the letter itself. Next slide, please. Lots of things for the future. I'm running over time. Next slide, please. We created a free toolkit that anyone can access, and we are here to provide support if you want to recreate this model in your own communities. You can reach out, you can scan that QR code, however you want to find us. Next slide, please. And so thank you so much. You heard today of 3 very different models where you can integrate, or where you can provide veterinary and human health care for people to improve the health of animals, improve the health of people. It is possible. It is powerful. We're all available to talk. Thank you so much.
Thank you, Vicki. Sorry you had to rush. This is amazing work. Thanks for this presentation, and thanks to all our presenters today. I am not seeing the slides, but we'll just keep on going. We should be on the Q&A slide right now, and we do have 2 very small minutes to go through questions. So I'll just start with the one that I see first. And this is for our One Health Clinic organizers. Did any of you consider consulting with or partnering with the Street Dog Coalition?
I can take that one. This is Kristen Jankowski. I went out to meet with John Geller and actually coached him about adding One Health Services to the Street Dogs Clinic before it had One Health Services. So yes, we've worked with them and they do great things. And I think we're a small community that all talk to each other a lot.
Wonderful, thank you. I'm going to skip down to our other presentation topic just because we may only have this last question. Let's see. What management strategies should be and please let me know if you can answer. I know one of our presenters might have had to drop off. So for the bird flu presentation, what management strategies should be advocated to prevent transmissions from domestic cats?
I can take that. Thank you. So just to clarify, was the question around transmission to and from domestic cats within the household? Is that the question? Whoever posted.
I don't know that they'd be able to respond so
Oh, I
quickly.
see.
So if you
Yes.
want to answer.
Yeah, I could answer. Yes, the recommendations around current, if there is exposure to H5N1, a known exposure for a cat, of course, as was mentioned in the slide, and also in our MMWR report, suggestions are provided. First, alerting your veterinarian and having the cat evaluated for any neurologic symptoms, respiratory symptoms, and identifying the source of exposure, occupational or otherwise, as was mentioned. If it's an exclusively indoor cat, occupational exposure obviously is the most important thing to ensure for the household members who are humans. And if the cat goes outside, of course, there's potential exposure from wild birds and other animals. And so if the cat is able to be evaluated by the veterinarian and tested, one of the things that's interesting is, like in Michigan, for example, at the time, there was a requirement for the state veterinarian to sign off on any type of H5N1 testing that was conducted. So initial flu swabs could be taken by local veterinarians, but then the samples would have to be sent in to the state lab. And so that required an okay by the state veterinarian. And so just ensuring, asking those questions of your veterinarian to make sure that there is follow-up in case the cat tests positive for flu, and that it could be sequenced and tested for H5N1. And as was mentioned earlier, one of the interesting things is that sometimes rabies shows up, and when tested negative, there is a recommendation from the USDA that if rabies is suspected in a feline and the feline tests negative, then those same samples can be tested for H5N1. So those are all things that could be done to ensure that other cats in the household are not being exposed if one of the cats is showing symptoms. But of course, there is, as was mentioned, publications that illustrate that cat-to-cat transfer is possible. And so those are similar to any other respiratory viruses that we would expect from grooming, shared grooming, and being in close vicinity. So isolating the cats in some way until there's known testing done. But I know Lisette might be able to maybe put some things in the chat, so maybe she could do that. But I hope that I answered your question.
Thank you very much. And our chat is closed. So if you do have any follow-up questions or any questions that you asked and didn't get an answer to, please feel free to email our presenters. Their email addresses are on the slide. They're also posted on our website and in the newsletter that we sent out today. A video of this webinar will be posted within 30 days. We are over time, so we're going to close out. Please stay tuned for an announcement of our next webinar on June 4th. And let me just go to the next slide. Thank you for your participation. This ends today's webinar. Thanks.
Thank you. Bye.